Hi, I'm Tom Inge, the Division Chief for Pediatric Surgery at Children's Colorado, and I'm joined today by Jose Diaz-Miron. His friends call him Pepe, and so I'll probably refer to him as Pepe during this session as well. And we're here to talk to you about pediatric inguinal hernias and surgical repair with a focus on laparoscopic repair. So Pepe, welcome.
Thank you, Tom. I'm a new assistant professor here at the division, and I'm excited to be here to talk to you about a common problem that we see in our pediatric surgery clinic.
So let's get right into it then, Pepe. The clinical problem of inguinal hernia in kids is something that's pretty common, and it's actually one of the favorite operations of most pediatric general surgeons. But can you just tell us a little bit about the incidence of inguinal hernias in babies and children?
It is one of the most common procedures that we perform as pediatric surgeons, and up to 5% of kids that we see here in the hospital or in clinic will present at some point with an inguinal hernia. It is more common in boys, about 10 times more common than girls, and even more common in kids that are born premature. So up to a third of the babies in the neonatal ICU will have an inguinal hernia detectable on physical examination.
Tell us a little bit about the developmental origins of an inguinal hernia and how it might differ a little bit from the boys and the girls.
For boys, typically what we counsel the parents regarding the natural progression of inguinal hernias is that testicles start in the abdomen and end in the final resting place in the scrotum. And there needs to be a communication between the abdomen that allows for this important structure to land in the scrotum. This is called the internal inguinal ring. Both boys and girls have a similar process in utero. Obviously, the girls don't have anything that's migrating, but the remnant of this, or the equivalent of this, is called the round ligament for girls. And in boys, it's just the important testicular structures that are attached to the testicle, the artery, the vein, and the vas. The problems with the obliteration of the processus vaginalis is what leads to the development of an inguinal hernia in a boy or a girl.
Yeah, absolutely. And then what do we see, and what do the pediatricians see? What do the families report that they see for the presentation of an inguinal hernia?
The majority of the time, the patients will report, or the parents will report, that they see a bulge. Sometimes it's during showers, during crying, during strenuous activities, or during bearing down as they're having a bowel movement. So that's the most typical scenario that we encounter in our clinic or in the hospital. However, there's a small subset of these patients that present acutely with an incarcerated hernia, meaning that something came out through the inguinal canal and is stuck there. It is more likely to have an incarcerated hernia as a first presentation in a pediatric patient than in an adult patient. Up to 15% of kids will present with an incarcerated inguinal hernia. However, in infants, you can see that in up to 30% of kids.
Yeah, and I'll jump in there too and say that it's been more than once that I've gone either to the emergency room or to a clinic to see an inguinal hernia, and you actually do feel a bulge or a mass there, and that can be there can be fake outs too, where you're actually feeling a hydrocele, maybe a defined hydrocele of the cord that is not reducible. Or just an inguinal lymph node is occasionally seen and represents a diagnostic dilemma. But most of the time, of course, we can, on really just history, what the parents have seen, what the pediatrician has seen, and our physical exam, sort out whether this is an actual inguinal hernia, or whether it's maybe some level of suspicion that it could be something else, and we might just get a simple ultrasound to sort that out.
Speaking of ultrasound, that's actually a question that I have very frequently from the parents that come to our clinic. Do we need an ultrasound to diagnose an inguinal hernia? And most of the times I say no. There are occasions, like you point out, where an ultrasound is important. especially when we're trying to differentiate between a hernia versus a hydrocele. So those are good scenarios where I actually do rely on the use of ultrasound, but the majority of the time, a good physical examination or a good story from the caregivers is good enough for me.
Sure. No, absolutely. I feel the same way. You know, and in terms of pivoting a little bit toward treatment, the inguinal area and an inguinal hernia is somewhat different than an area that's just usually a few centimeters away in the umbilical area, where if we see an umbilical hernia and it's in a patient that's not yet school age, we'll usually give reassurance to those family members and say, you know, these typically will resolve and shrink and really completely heal themselves by the time your son or daughter needs to go to school. But inguinal hernias are different. They really do, I think, have a different anatomic configuration and a different behavior. And they don't get better with time like an umbilical hernia should. So what is your preferred approach then surgically to repairing these hernias?
I totally agree with you, Tom. I have the same approach to my families. Umbilical hernias delay, inguinal hernias, I typically like to fix them within the next couple of weeks because of the same risk of incarceration that we just talked about. It happens rarely, but when it happens, it turns an elective procedure into something that's urgent or emergent. My typical approach for inguinal hernia repair is a laparoscopic high ligation of the sac, which involves entering the abdomen and using the advantage of laparoscopy and insufflation of the abdomen to take a look at the site where we know that there is a problem and repair that site with a purse string suture that is placed from the inside of the abdomen. So what we're able to see intraoperatively when we're doing a laparoscopic repair is the actual process of vaginalis, that is the reason for the inguinal hernia. The advantage of doing this procedure laparoscopically is that you can focus on the side that you know has an issue, but it's very easy to just look at the contralateral side and make sure that that side is completely closed as well. There are several times when I see a contralateral inguinal hernia that's detected intraoperatively during the laparoscopic repair. And the advantage of already being in the abdomen is that it's very easy to focus your attention on the opposite side and repair that.
And Pepe, tell us, obviously pediatric surgeons for many, many decades have repaired inguinal hernias, one of the most common operations that we do, and have done this using an open technique. Do you see any major differences that families should know about or pediatricians should know about between the two? Are there some advantages to open repair that you are not apparent in the laparoscopic repair?
Typically, what I tell parents is that a surgeon should perform the procedure that they're comfortable performing, and both open and laparoscopic inguinal hernia repairs have very good outcomes. Both of them have similar recurrence rates. Both of them have similar cosmesis following the repair. Both of them have equivalent pain control outcomes after the procedure. There are a few minor advantages to the laparoscopic approach. One is the fact that you're able to see the contralateral side, as we just mentioned, and repair contralateral hernia that may not be clinically apparent at the same time. And there are some reports that talk about a laparoscopic approach having a lower incidence of wound infection, although the wound infection rate for both open and laparoscopic is very low to begin with.
Yeah, and I would 100% agree that really there's not a lot of advantages or disadvantages either way. Both are very good ways to repair. I think the literature would show some studies that really support this concept that you mentioned, which is you can see the other side obviously very well with a laparoscopic repair. And so sometimes those patients that come in and just get one side repaired, the side where there is the bulge, will come back, potentially a year or two later with a hernia on the other side if it's done open and no one has actually been able to look at the other side. So I think that is a real advantage of the laparoscopic approach. So if you don't mind, tell us a little bit about the actual technical details. When you do a laparoscopic hernia repair, for instance, you have a camera, say, in the a belly button. And then how do you go about, actually ligating that hernia neck?
My typical approach is starting the laparoscopic operation with 3 incisions, 1 in the umbilicus for the camera, and then 2 on each side of the umbilicus for my working instruments. Those working instruments allowed me to place a purse string suture around the internal inguinal ring and achieve our high ligation that we like to talk about in pediatric surgery of the sac. In boys, we pay quite a bit of attention to the structures that are traversing the internal inguinal ring, meaning the artery, the vein, and the vas. And we take great care in kind of jumping over these important structures so that they're not incorporated into the final purse string and allow for a good repair while maintaining the integrity of these important structures. In girls, we don't have to worry about this, and the round ligament is incorporated into the repair.
Right, and I think you're describing what's called the intracorporeal sewing technique, and I think that that's a perfectly fine technique. What I've done most commonly is an extracorporeal ligation, really, where I'll put the scope in the umbilicus, usually one other grasping instrument into the abdomen and through a tiny little incision, and then a very tiny little incision right over the hernia itself, maybe a 2 millimeter incision, passing a needle around the hernia sac, the neck of the hernia, if you will, and then just ligating it right there without the intracorporeal sewing that you talk about. But again, when the studies have been done, the outcomes of these are truly trivial. They're not different at all in terms of outcome. They're both very highly effective, just like the open repair. And speaking of outcomes, Pepe, what do you counsel parents in terms of, a risk of recurrence of that hernia after you do a inguinal hernia repair?
So I talked to them about a very low risk of recurrence comparable to the open approach. And typically I quote in the order of a couple of percentage points for a repair that's either open or laparoscopic. Most of the times, it's a one and done thing, and patients will do quite well after the operation. But I do have a frank discussion with our patients and their parents and talk about the possibility of a recurrence. And if it were to happen again, we would address it at a later time.
Right. And just with any other operation that we do go over the possibility, just because of structures that are in the area and adjacent to the area of the repair, we always talk about the possibility of injury to the vas, injury to the vessels for completeness. But again, the risk of something like that happening, particularly with good visualization of all of this anatomy as we have, is really, really quite small, quite far below 1%.
Correct. And the operation is actually quite well tolerated by most of our patients. They go home fairly quickly after the operation. The majority of the time, it's an outpatient procedure for most of our patients, and they're discharged home with just Tylenol and Motrin, something over the counter that will help control the pain. There are a few instances where we do keep patients overnight, mainly when we're dealing with a premature infant that has not been corrected to 50 weeks post-conception. And for that reason, we keep those patients overnight just to monitor for the rare risk of apnea prematurity that could happen overnight.
Sure. No, I absolutely agree with that as well. And then what do you tell your families? Let's say you're doing a consult in the office. You've got a 6-month-old, there's a bulge, you can reduce it easily on your exam. And the family has said that they do the same at home during a bath or whatnot. What do you tell them, then before that patient's OR date comes up, if they were to feel that this hernia is not reducible anymore?
I have a very long discussion during my preoperative evaluation for any of these patients and talk to them about how this is an elective procedure unless it becomes incarcerated, and then it turns into an urgent / emergent situation. So if the hernia continues to be reducible, spontaneously reducible, most of the times you'll see a child that cries and the hernia comes out. When they stop crying, it's back in, or the patients are able to push it back in themselves. Then this is still an elective procedure. I usually try to fix these hernias, as we chatted before, within the 2-week range, just to mitigate the potential risk for incarceration after seeing them in clinic. But once we get to the operating room, it's a quick procedure that should get them home within the same day.
Well, I really appreciate that. I think, again, this is one of those operations that, represents, again, a common condition for kids and babies. It represents an operation that is overwhelmingly successful. And as pediatric surgeons, of course, we love to do operations where we're fixing something that is a clinical problem and has the potential to really do pretty significant harm if left untreated, and get these families and children back home same day and really back to their usual activities completely, back to all of their activities, really certainly by the next day. All right, Pepe, I think we've really covered this topic quite well, talking about the anatomy, the pathophysiology, and surgical repair of pediatric inguinal hernias using open as well as laparoscopic techniques. To read more about it, please visit us on our website, and we'll be happy to see your patients.